Today we're going to say about obstetrical anesthesia. This was first discovered by Dr. John Snow, who was born in 15th March in New York, England. Queen Victoria was given the chloroform by John Snow for the birth of her eighth child, and this did much to popularize the use of pain relief in labor. This was the major content about Dr. John Snow. So here, while going to the content, does labor pain need analgesia? Analgesia for labor and delivery. They are always controversial. This topic is. As we know that birth is a natural process, women should suffer. This is a fact. There's concerns for the women's safety and concern for the baby, concern for the effect of labor is much needed here. Why have a caregiver dedicated to pain management during the labor and delivery? So, labor and delivery, they result in the severe pain for most women. In an attempt to quantify this pain, parturients were asked to rate their pain during the labor. This result were then compared to the values obtained from the patient in a general pain clinic and the emergency department. The pain of childbirth was greater than the fractured arm and the cancer pain. Only coccygia and the amputation of the digit exceeded the pain of labor and the delivery. Parturients described the pain as a sharp, cramping, itching, throbbing, stabbing, hot, shooting, and tight one. What is the cause of the labor pain in the stage 1? What type of pain is it? The pain resulting from the first stage of labor is primarily due to the dilation of the cervix with consequent distension and stretching. As the uterus contracts, the fetal head pushes against the cervix and causes the dilation. Therefore, stage 1 pain generally occurs only during the uterine contraction, while the majority of our pain during this stage occurs from the fetal head pushing against the cervix. There is also a pain from pressure on the stretching of the uterine muscle, which activate the high threshold mechanoreceptor. In the first stage of labor, the pain is visceral. It is strong and dull and occurs over the lower abdomen between the umbilicus and symphysis pubis, laterally over the iliac crest, and posteriorly in the skin on the soft tissue over the lower lumbar spines. The next thing we're going to see is the location of the labor pain in stage 1. The location of this pain is explained by the concept of referred pain. The sensory nerves of the uterus and the cervix leave the cervix and join the sympathetic nerves as they pass through the hypogastric plexus to the sympathetic chain, synapsing within the dorsal horn of the spinal cord at T10, T11, T12 and L1. Mind that the dorsal horn of the spinal cord at T10, T11, T12 and L1. Because of the sensory nerves in the uterus and cervix, hypogastric plexus to the sympathetic chain. This area of the spinal cord receives not only this visceral high threshold efference but also the low threshold cutaneous efference of the skin from T10, T11, T12 and L1. With the convergence of both somatic and the visceral fibers within the same area of the spinal cord, the parturient interprets the uterine pain as originating from the cutaneous efference of this spinal segment. The pain is referred to this area. Next question that is rising in our mind is, what is the cause of labor pain in stage 2? What type of pain is it? Second stage pain occur as the fetus descends through the birth canal. This results in stretching and the tearing of the fascia, skin and the subcutaneous tissue. This somatic pain is transmitted primarily through the pudendal nerve. The pudendal nerve is derived from the anterior primary divisions of the sacral nerve S2, S3 and S4. Of note, the fetus often begins to descend during the first stage of labor. During the transitional stage of the first stage, it is not uncommon for the mother to experience both visceral and the somatic pain. Labor pain at a different stage of labor. In the first stage, they are almost a moderate one. In second stage and the postpartum stage, they are at the peak. The physiology of pain in the labor. The first stage of labor, mostly visceral one. Dilation of cervix and the distension of the lower uterine segment. They are dull, itching and poorly localized, slowly conducting one, visceral C fibers and they enter the spinal cord at T10 to TL1, as I said before. In the second stage of labor, they are mostly somatic one. Distension of the pelvic floor, vagina, and the perineum. They are sharp, severe, and well localized, rapidly conducting A delta fibers enter the spinal cord at S2 to S4. Pain pathways of the labor, as I said before. Labor. They mostly affect the respiratory one, gastrointestinal one, post-traumatic stress syndrome, neuroendocrine one, urinary, and the cardiovascular one. Painful urine contraction causes the maternal hyperventilation. Hypocarbia results in the hyperventilation between the contraction. Hypocarbia shifts the maternal oxyhemoglobin dissociation curve to the left and increases the oxygen affinity. They reduce the fetal oxygen delivery. How do physiological psychological factors influence the pain labor? While labor is the physiological processes, the psychological factors also affect the pain. Anxiety is a particularly powerful factor in reducing the pain tolerance. How? Attention, the selective orientation of the receptor system to one source of pattern to the stimulation to the exclusion of the other sources either the enhances or diminishes the painful experience. Motivation is another psychodynamic mechanism that can have the marked influence on the physiologic, behavioral, and the affective aspects of pain. Breathing exercise divert the mother's attention from the pain of contraction. Pain relief in labor presents a unique problem. Labor begins without the warning, and obstetrical anesthesia may be required within the minutes of the full meal. Vomiting with aspiration of the gastric content is a constant threat that poses a serious maternal morbidity and mortality. Moreover, a host of disorders unique to pregnancy, such as preeclampsia, placental abruption, and chorioamniotis, all superimposed on the unique physiological adaptations of pregnancy. They are directly affected by the choice of analgesia, and anesthesia is selected. Anesthesia complication. They are caused by 1.6% of the pregnancy-related maternal death. Several factors likely have contributed to improved safety of the obstetrical anesthesia. The recent trend towards increased use of the regional analgesia rather than the general anesthesia may be the most significant factor. The increased availability in-house anesthesia coverage almost certainly is another important reason. Gender principle. A woman's request for the labor pain relief is sufficient medical indication for its provision. It is the responsibility of the obstetrician or the certified nurse midwife in consultation with an anesthesiologist, if appropriate, to formulate a suitable plan for the pain relief. Identification of any one of the risk factors should prompt the consultation with the anesthesia personnel to permit a joint management plan. This plan should include the strategies to minimize the need for emergency anesthesia in women for whom such anesthesia would be especially hazardous. Maternal risk factor that should prompt the anesthesia consultation. Marked obesity, severe edema, or the anatomical abnormalities of face, neck, or spine, including the trauma or surgery. Abnormal dentition, small mandible, or difficulty in opening the mouth. Extremely short stature, short neck, or arthritis of the neck, goiter. Serious maternal medical problems such as cardiac, pulmonary, or the neurological disease, bleeding disorder, severe preeclampsia, previous history of anesthetic complication, obstetrical complication likely to lead to operative delivery, example placenta previa, or higher order multiple gestation. Here we can go for the goals for optimizing the obstetrical anesthesia services. Availability of the licensed practitioner who is credentialized to administer an appropriate anesthetic whenever necessary and to maintain the support of vital functions in the obstetrical emergency. Availability of the anesthesia personnel to permit the start of the cesarean delivery within 30 minutes of the decision to perform the procedure. Anesthesia personnel immediately available to perform an emergency cesarean delivery during the active labor of a woman attempting the vaginal birth after the cesarean. Appointment of the qualified anesthesiologist to be responsible for anesthetic administered. Availability of the qualified physician with the obstetrical privileges to perform the operative vaginal or the cesarean delivery during the administration of the anesthesia. Availability of equipment facilities and support the personnel equal to that provided in the surgical suite. Immediate availability of the personnel other than the surgical team to assume the responsibility for the resuscitation of the depressed newborn. Role of obstetrician. Every obstetrician should be proficient in the local and the prenatal analgesia. Regional analgesia may be administered by the properly trained obstetrician in appropriately selected circumstances. In general, however, it is preferable for an anesthesiologist or the anesthetist to provide this care so that the obstetrician can focus the attention on the concern for the laboring women and the fetus. General anesthesia should be administered only by those with the special training. Principles of pain relief. The experience of the labor pain is highly individual reflection of the variable stimuli that are uniquely received and interpreted by each woman individually. These stimuli are modified by the emotional, motivational, cognitive, social, and the cultural circumstances. The complexity and the individuality of the experience suggests that the women and the caregivers may have the limited ability to anticipate a pain experience prior to labor. Thus, choice among the variety of method and the individualization of the pain relief is desirable. Goals of the labor analgesia: dramatically reduce the pain of labor, should allow the parturient to participate in the birthing experience, minimal motor block to allow the ambulation, minimal effects on the fetus, minimal effects on progress of labor. Here we can look what analgesic options are available for labor and what are all the types of labor analgesia. Here we can look the types of labor analgesia: non-pharmacological, pharmacological, regional, general anesthesia. Non-pharmacological methods of pain control: fear and the unknown potential pain. Make a woman who is free from fear and develop the confidence in the obstetrical staff that cares for her. Avoid the emotional tension. LAMIS, teaching pregnant women relaxed breathing and the labor partner's psychological support techniques. Motivation: the presence of the supportive spouse. Analgesia and the sedation during the labor. Analgesia and sedation during the labor: when the uterine contractions and the cervical dilation causes the discomfort, pain relief with the narcotics such as mepridine plus one of the tranquilizer drugs such as promethazine is usually appropriate. With a successful program of the analgesia and the sedation, the mother should rest quietly between the contraction. In these circumstances, discomfort usually is felt at the acme of an effective uterine contraction, but the pain is generally not unbearable. Neuroaxial opioids. The following opiates have been used: morphine, fentanyl, subfentanyl, meperidine, diamorphine. Parenteral agents for the labor and pain: 1 to 2 new drugs: chlorine, neostigmine, midazolam. Parenteral agents: meperidine and promethazine. 50 to 100 mg promethazine, 25 mg may be administered intramuscularly at the intervals of 2 to 4 hours. The more rapid effect is achieved by giving the methadone intravenously in doses of 25 to 50 mg every 1 to 2 hours, whereas the analgesia is maximal about 30 to 45 minutes after the intramuscular injection. It develops almost immediately following the intravenous administration. Meperidine readily crosses the placenta and the half-life is approximately 13 hours or longer in the newborn. Butorphanol, the synthetic narcotic given in the 1 to 2 mg doses, compares favorably with 40 to 60 mg of the methadone. The major side effects are the somnolence, dizziness, and the dysphoria. Neonatal respiratory depression is reported to be less than with the methadone, but care must be taken that the two drugs are not given contiguously because butorphanol antagonizes the narcotic effects of the methadone. A sinusoidal fetal heart rate pattern following the butorphanol administration. Fentanyl. This short-acting and the potent synthetic opioid may be given in the doses of 50 to 100 mg intravenously every hour. Its main disadvantage is a short duration of action, which requires a frequent dosing or the use of patient-controlled intravenous pump. Efficiency and the safety of the parenteral agent. Methadone, this is the most common opioid used worldwide for the pain relief in labor. There is no convincing evidence demonstrating that the alternative opioids are better. There is no evidence that the parenteral opioids influence the length of labor or need for obstetrical intervention. Epidural analgesia provides a superior pain relief. Intravenous and the intramuscular sedation are not without the risk. Maternal anesthetic related death from such sedation, aspiration, inadequate ventilation, and the overdosage. Moreover, methadone or the other narcotics used during the labor may cause a newborn respiratory depression. Narcotic antagonist. Naloxone, this is a narcotic antagonist capable of reversing the respiratory depression induced by the opioid narcotics. It acts by displacing the narcotic from specific receptors in the central nervous system. Withdrawal symptoms may be precipitated in the recipients who are physically dependent on the narcotics. For this reason, naloxone is contraindicated in the newborn of the narcotic addicted mother. Along with the proper ventilation may be given to reverse the respiratory depression in the newborn infant whose mother received the narcotics. Nitrous oxide. A self-administered mixture of 50% nitrous oxide and oxygen provides a satisfactory analgesia during the labor for many women. Some preparations are pre-mixed in a single cylinder, Entonox, and in others a blender mixes the two gases from the separate tanks, Nitronox. The gases are conducted to a breathing circuit through a valve that opens only when the patient inspires. Nitrous oxide. The use of intermittent nitrous oxide for the labor pain, the following technique suggested. Instruct the women to take slow, deep breath and to begin inhaling the 30 seconds before the next anticipated contraction and to cease when the contraction starts to recede. Remove the mask between the contraction and encourage her to breathe normally. No one but the patient or the knowledgeable personnel should hold the mask. Instruct the caregiver to remain in a verbal contact with the patient. Provide the expectation that the pain will likely not be eliminated but the gas should provide some relief. Ensure the intravenous access, pulse oximetry and adequate scavenging of the exhaled gases. Use with the additional caution after the previous opioid administration because the combination can more easily render a woman unconscious and unable to protect the airway. Regional analgesia. Regional anesthetic techniques were introduced to obstetrics in 1900, where Oscar Croix described the use of spinal anesthesia. Unfortunately, he was an obstetrician. Regional anesthesia. Various nerve blocks have been developed over the years to provide the pain relief during the labor and delivery. They are correctly referred to as regional analgesics. Regional anesthesia can be given in epidural, spinal, combined spinal epidural, continuous spinal analgesia, paracervical block, lumbar sympathetic block, pudendal block, perineal infiltration. Sensory innervation of the genital tract and the uterine innervation. Sensory innervation of the genital tract, uterine innervation. The pain during the first stage of the labor is generated largely from the uterus. Visceral sensory fibers from the uterus, cervix, and the upper vagina travels through the Frankenhauser ganglion, which lies just lateral to the cervix into the pelvic plexus and then into the middle and the superior internal iliac plexus. From there, the fibers travel in the lumbar and the lower thoracic sympathetic chains to enter the spinal cord through the wide ramic communicants associated with the T10 through T12 and L1 nerves. Early in the labor, the pain of the uterine contraction is transmitted predominantly through T11 and the T12 nerves. Uterine innervation. The motor pathways to the uterus leave the spinal cord at the level of T7 and T8 vertebrae. Theoretically, any method of the sensory block that does not also block the motor pathways to the uterus can be used for the analgesia during the labor. Lower genital tract innervation. The pain with the vaginal delivery arises from the stimuli from the lower genital tract. is transmitted primarily through the pudendal nerve, the peripheral branches of which provide the sensory innervation to the perineum, anus, and the more medial and the inferior parts of the vulva and the clitoris. The pudendal nerve passes beneath the posterior surface of the sacrospinous ligament, just as a ligament attaches to the ischial spine. The sensory nerve fibers of the pudendal nerve are derived from the ventral branches of the S2 through the S4 nerves. Anesthetic agents. Some preparation that contain dilute epinephrine to prolong the action of the anesthetic will also cause the symptoms when the test dose is inadvertently given intravenously. The dose of each agent varies widely and is dependent on the particular nerve block and the physical status of the woman. The onset, duration, and the quality of the analgesia can be enhanced by increasing the dose. This can be done safely by only incrementally administering the small volume boluses of the agent and by carefully monitoring for early warning signs of toxicity. Administration of this agent must be followed by appropriate monitoring for the adverse reaction, and equipment and the personnel to manage this reaction must be immediately available. Most often, the serious toxicity follows the inadvertent intravenous injection. For this reason, when the epidural analgesia is initiated, dilute epinephrine is sometimes added and given as a test dose. A sudden significant rise in the maternal heart rate or the blood pressure immediately after the administration suggests intravenous catheter placement. Personnel using these agents must be cognizant that these agents are manufactured in more than one concentration and ampule the size, which increases the potential for dosing errors. Some local anesthetic agents used in the obstetrics: chloroprocaine, tetracaine, lidocaine, bupivacaine, ropivacaine. An addition of glucose to local anesthetics creates the hyperbaric solution, which is heavier and denser than the cerebrospinal fluid. Toxicity. Systemic toxicity from the local anesthetics typically manifests in the central nervous and the cardiovascular system. Central nervous system toxicity. Early symptoms are those of the stimulation, but as serum level increase, depression follows. Symptoms may include lightheadedness, dizziness, tinnitus, metallic taste, and numbness of the tongue and mouth. Patient may show the bizarre behavior, slurred speech, muscle fasciculation and excitation, and ultimately generalized convulsion followed by the loss of consciousness. The convulsion should be controlled and RV established and oxygen delivered. Succinylcholine abolishes the peripheral manifestation of the convulsion and allows the tracheal intubation. Thiophanate or diazepam acts centrally to inhibit the convulsion. Magnesium sulfate, administered according to the regimen for the eclampsia, also control the convulsion. Abnormal fetal heart rate patterns such as the late deceleration or persistent bradycardia may develop from the maternal hypoxia and the lactic acidosis induced by the convulsion. With the arrest of the convulsion, the administration of the oxygen and the application of the other supportive measure, the fetus usually recovers more quickly in the utero than the following immediate cesarean delivery. Moreover, the maternal well-being is usually better served by waiting until the intensity of the hypoxia and the metabolic acidosis have diminished. Cardiovascular toxicity. These manifestations generally develop later than those for the cerebral toxicity. The notable exception is bupivacaine, which is associated with the development of neurotoxicity and cardiotoxicity at which visually identical serum drug level. Because of the risk of systemic toxicity, the use of 0.75% solution of the bupivacaine for epidural injection was prescribed. Cardiovascular toxicity. Similar to the neurotoxicity, the cardiovascular toxicity is characterized first by the stimulation and then by the depression. Accordingly, there is a hypertension and the tachycardia, which soon is followed by the hypotension and the cardiac arrhythmia. The latter contribute appreciably to impaired uteroplacental perfusion and the fetal distress. Hypotension is managed initially by turning the women onto either side to avoid the autocaval compression. A crystallized solution is infused rapidly along with the intravenously administered ephedrine. Emergency cesarean delivery should be considered if maternal vital signs have not been restored within 5 minutes of the cardiac arrest. As with convention, however, the fetus is likely to recover more quickly in the utero once maternal cardiac output is re-established.